price program, as Bill explained last time. That's the major joint surgeries, and then the dental hardware, and then also the bariatric surgery. So I'm going to talk about them each separately. So for the major joint prior authorization process, providers submit prior authorization requests for those through EviCore. And EviCore responds to those requests within 2 business days. And when EviCore responds, they send a letter out to both the member and to the provider requesting the prior authorization. So if the requested facility is a reference-based price facility, then both the provider and the member receive a letter that states that the procedure is approved. And so it's just a standard letter that goes out saying, yes, this is approved. However, if the requested facility is not a reference price facility, then both the member and the provider receive a letter that states the procedure is approved, but that the facility may charge over the reference based price. So that is explained very clearly in the letter. And then the letter also states to call MODA if they have questions about that, and really direct them to us so that we can help them find a facility that is in the reference-based price program. There are not many requests that come in for facilities outside of the reference price program, so that's not something that happens often. All right, and then so for bariatric surgery and the oral appliances, those prior authorizations are both handled internally by MODA. So for bariatric surgery, that surgery is only covered at a centers of excellence. So if we receive a request for a facility that is not a COE, then that request is actually denied because the procedure just would not be covered at that point. And MODA would send a letter to both the provider and the member notifying them of that approval or the denial for the procedure. For oral appliances, all of in-network providers are at or below the reference price. Oral appliances are covered out of network, unlike the bariatric surgery. When the request comes in, we would send out a letter to the member letting them know if the requested oral appliance is an in-network provider or an out-of-network, and if the out-of-network one, then we indicate that they may be balance billed above that contracted amount. So that's all I've got. Does anybody have any question about those communications?
Erica,
yeah, this is
Jeff.
Mm-hmm.
Going back to the major joint, how many facilities are not accepting reference pricing? Do you have any idea?
There's a few, and I can go and pull that number. There's a list on our website of all of the facilities that do accept a reference price, but there are a few that do not. So I can get that number together for you.
Is there a region where the ones that don't kind of cluster, or is it just a dot here and there throughout the state?
Because of any facility that is subject to the hospital cap rules is in the reference price program. Most of those facilities are in the I-5 corridor. So there's really not a lot of, meaning there's coverage all throughout that part of the state. Because, oh, go ahead.
So all the DRG hospitals.
Yep. All of the DRG hospitals are in. So that would just mean that any facility that wouldn't be in would be outside of that range. So more would be in Eastern Oregon and Southern Oregon, but there are definitely facilities in those locations as well. So I will follow up just on where there might be a gap as well.
Thank you.
Mm-hmm.
Erica.
Yeah.
And I'd actually also like Ali to answer. We've had this program in place for some time, and I think we've asked this before, but it'd be helpful to confirm that there really hasn't any recent significant number of complaints or concerns about what we do with this program. Is that correct? From MODA standpoint and OEB administration standpoint?
Yeah, from MODA standpoint, if there was a concern about this program, I would most likely hear it, and I have not heard a concern about it maybe once in the 5 years I've been at MODA.
Okay, thank
Yeah,
you.
it's the same from the web admin, Tom.
Okay,
It's really, we've heard nothing.
okay. So it's an established program. I think we've talked about it, the savings that are associated with it, and the changes in terms of utilization. It's been around for a long time. And many things have changed in the environment. We went through the Summit Synergy process, and now we have the impact of the impact of the Senate bill, the 200% of Medicare. So I think our assumption now is, and our recommendation, I think SEOW's recommendation to the board is that it's a program, it's up and running, it's had some impact, that impact has been moved and twisted by history, and yet our recommendation is to continue the current process for the 3 elements that are listed out. Is that a fair recommendation for SEOW to the board?
From my perspective, yeah, that's a fair recommendation, Tom.
And the only other point that was raised, I think, at our last discussion of this was by Bill, who requested that it said it would make sense for us to look at what's included on this reference list and see whether or not we want to change it, and that review should be every 2 to 3 years. I think what is going to overtake that recommendation is the innovation work group that is looking at things such as expert medical opinion and other centers of excellence. So I think we should keep this program in place, and it's very possible that we should, over the next year, depending upon how the innovation work group works through those 2 initiatives that I just mentioned, we may want to look to whether or not we want to expand the list. Is that fair?
Hey, Tom, this is Bill. Just the logistics that Jeff has his hand raised in the window.
Oh, I see it. Yep.
Yeah,
Thank
but how
you.
do I get rid of it? Because I
Just press it again. Just press the same button.
Yeah, it went away.
It did?
Yeah,
No,
it's gone now.
Oh, it still shows in the bottom.
not for me.
Screen.
Oh, I see it. Yeah. Okay, Jeff.
An analog guy stuck in a digital world.
You're not alone, buddy. Jeff, your comment on what I just said?
I didn't. That was from before, and I already asked Erica the question.
Okay.
Thank you.
Comment just on the recommendation to the board from Robert and Bill and Jeff.
This is Bill. I'm good.
Okay.
Yeah, I'm good too. I definitely would like to review it later on just to see if it's still effective with all the, or necessary with all the other changes coming online.
Okay, good. All right. So are we able to move on? Thank you very much, Erica.
Thank you all.
Okay, so our next presentation is by Kaiser Permanente, and we're going to be hearing about the provider incentive program. And I have written down on the agenda that Dr. Ruth Chang is going to lead us through this. Is that correct?
That's correct.
Yes. That's correct. This is Keith, and I'll take just a moment to introduce Dr. Chang.
Thank you, Keith.
She is our for Northwest Permanente, which is a medical group attached to Kaiser Permanente. She's the Chief People Officer and the Vice President for People Operations. Additionally, she's a family practitioner by training and practice, and she's been as the past president of the Oregon Academy of Family Practice. In her administrative career, she's been a great advocate for equity, inclusion, and diversity, and really for the importance of caring for our clinicians and retaining the joy of practice. It's really the fourth part of the triple aim that we care about a lot, because we know if our clinicians aren't happy and engaged, they will not be effective in taking care of our members. Just a little point of terminology. We don't usually sort of split between Northwest Permanente, which is the medical group that is essentially has a sole provider relationship with Kaiser Foundation and Health Plan, or the full entity we call Kaiser Permanente, but it's really two entities that have mutually beneficial collaboration. The medical group, which is Northwest Permanente, and then the health plan and hospital group, which is Kaiser Foundation for the Northwest. So that also provides the insurance. So with that, I will turn it over to Dr. Chang.
Great. Thanks so much for that introduction, Keith. It's my pleasure and honor to get to speak with our OEB SEOW group today. Just a little personal background. Both my parents are retired teachers, and somehow I took a left turn in college and ended up in medical school, but they forgave me for that. But definitely, it's a pleasure and honor to take care of our educators and all the staff who help make education happen in this state. So definitely love the teachers who are on my panel and all the staff. So with that, it's definitely my pleasure to share with you about the provider incentives. And as Keith had already mentioned, we don't typically talk about the medical group necessarily separately from the Kaiser Foundation Health Plan. But in this case, when we're talking about incentives, we do want to give you a little bit more behind the scenes look at how we align our incentives with our overall goals and mission of providing the best care, more affordable care to all of our members. So we'll move to the next slide. This was just an introduction slide, so we can move on to the next slide on that. So really, Kaiser Permanente is about care and coverage. We have our insurance arm and the care delivery arm completely integrated. And for us, what that means is we can really optimize the health of our members, provide more efficient, coordinated care, and then ultimately to help manage costs, which I know has just been the big concern in this country as we continue to see the rising costs of healthcare. So next slide. So in this integrated care model, then, this slide really illustrates how the medical group is paid in total from our health plan partner. And then later on in a few more slides, I'll talk about how each individual clinician is paid under the same model. So contractually between the medical group and the health plan, we do go through an annual memorandum of understanding. So we go through a negotiation process, really with the goal of landing on what is our capitated rate of payment. So that is our per member per month payment that we would receive from the health plan for really the care delivery arm of our plan. So these capitated rates will vary for each line of business. So by commercial member, Medicare, Medicaid, those rates do vary. And we also in this yearly MOU really outline how we would pay for additional incentive metrics. And those incentive metrics would be set around quality targets, service targets, as well as financial targets for our overall program. And next slide. So looking at quality and service in particular, we definitely have a long list of quality and service metrics that we're working towards each year, and we continue to keep moving the goalposts, if you will, in order to make sure we're continuing to improve year over year. And these metrics are agreed upon between the health plan and the medical group each year. Now, the good news for OEB is that many of these high priority quality metrics really align with the OEB performance metrics as well, because I know certainly you, as one of our key customers, want to ensure the best outcomes for your members. We want the same thing as well. So this is just a high-level overview of some of those key metrics, and you can see that the ones that are have the asterisks are ones that are on the OEB metric scorecard as well. So, for example, the childhood immunization status, comprehensive diabetes care with A1C control, and breast cancer screening are the ones that align with OEB performance metrics. In addition, we're also looking at hospital high priority composites. So looking at some of those preventable causes that drive up costs, such as infections per patient days, opioids that are dispensed per 1,000 surgeries. Are we treating pain adequately, but not too much? And then certainly equitable care. Is our diabetes control, are we doing well across all populations? And then if there's a gap, what's our plan to close that gap? So this is an overview of our quality metrics, and certainly there are patient satisfaction or service metrics as well. Next slide.
Let's see.
Do we have a question?
Yes, please. On the bottom right, equitable care. A1C3 less than 8.
Mm-hmm.
Could you just kind of explain what those measures mean?
Sure. That's a great question. So in this one, it's really looking to see in our diabetes control, we want certainly that hemoglobin A1C, the number lower the better. We do consider patients to be under fair control if their number is at 8% or less. What we've seen over the years when we've split out the diabetes control numbers by demographics, in this particular case by ethnicity and race, we saw that the Latino population had much poorer diabetes control. So their percentage of patients with diabetes who have A1C level of less than 8% was significantly less than white or Asian populations. And then we said, nationally, KP said, oh my goodness, what are we going to do about this? And so some of the things that we have put in place to really help address these is we now have community health workers who outreach to our Latino patients, and we set up the Salud en Español. So we have modules within our clinics where the physicians, the MAs, the nurses all speak Spanish so that we can deliver language concordant care and culturally appropriate care to our members. And that has really shown to be effective in helping improve the diabetes control of that population, in addition to just delivering better care experience overall. Yeah.
Ruth,
does that answer your question?
Thank you.
Ruth, this is Tom.
Yeah.
Question would be just so when you looked at that, we're going to be spending time in the afternoon on our overall OEB meeting talking about equitable care. So I was very interested when I saw this. Does this then assume that when you look at what's happening with the African American community within KP Northwest and potentially then Pacific Islanders as a group, that they are closer to what we're seeing in the white population and Asian? Or was it that the Hispanic/Latino was where it was most significantly askew?
Mm-hmm. Yeah, so this is a sampling of some of our high priority measures. So one of the other metrics that we look at on a national level too is hypertension control in African American population.
Okay.
Traditionally, there's been a gap there as well,
Okay.
and we're working to close that gap.
Okay.
And then you're absolutely right that with Pacific Islanders, there's certainly diabetes control issues, and then just around meeting unmet social needs. So like, for example, in our Salem area, we have the Marshallese Chickees speaking population who were really disproportionately impacted by COVID. And plus just around access to care and finding language interpreters to ensure high quality care each time. So that's been a challenge. Our solution to that is we've hired a patient navigator who speaks Chickees. So a patient navigator from within the community to really help bridge that gap and help.
I'm not trying to move this down a different. I just was interested in that, and I'm sure we'll have more conversation about that this afternoon. But thank you very much. I'm very I'm very pleased to see that that type of effort looking at more vulnerable populations has been included in that. From back in the days when I was with Northwest Permanente, we weren't sophisticated enough to do that.
Mm-hmm. Yes, thank you, Tom. And clearly, equity, inclusion, diversity is my passion, so it's easy for me to kind of go down a tangent. So, but we're always happy to come back and present on our EID.
Yeah, we may take you up on that. Thank you.
Great. I welcome the opportunity. So back to today's topic. This is now about compensation and benefits for individual clinicians. So we already talked about how we as a whole medical group, we have the capitated payment from health plan plus the quality service and financial incentives for performance. And so really that translates to our individual clinicians as well. So our individual clinicians are paid on a base salary, and they all have an exclusive service contract with Northwest Permanente. We are using national benchmarks around physician compensation to really help set our base compensation. And we purposely set the target at 90% of the national median of the specialty. So we wanted to be competitive on the base pay and then offer, in addition, a very good benefits package, really for long-term retention. So this was by design, where we chose specifically to pay at 90% of the national median, so just a little under the national median based on specialties. And then we certainly offer full medical, dental insurance, but our members also, or our own employees also have the option of choosing a high deductible health plan option. And over a quarter of our Northwest Perm employees are on that high deductible health plan, which has been a great way for people to learn about the cost of healthcare, when they're having to pay attention to their own medical bills. And then certainly we have benefits such as retirement and paid leave. And those, when we benchmark against the national surveys, we are above average for those. So on this slide, we're just showing a direct quote from one of our clinicians, is really saying, I can't imagine having a career elsewhere. We can practice and focus on the practice of medicine, not generating revenue or having to negotiate with insurance companies. And so I think that really speaks to one of the main attracting pieces of practicing at Northwest Permanente, is that autonomy in clinical practice. I personally chose to practice at Northwest Permanente because one of the main things is I didn't want to have to fill out prior authorization form for every test I wanted to order. Now, certainly I get feedback around my imaging utilization and test utilization. I get feedback, and certainly we have physicians who do second reviews for MRIs for select body imaging areas. So we really kind of get feedback peer to peer rather than having to go through an insurance process. So that's one of the key things about our practice. So next slide. And in addition to compensation and benefits, we also really think about what's our total reward strategy. Why would a clinician choose to practice with Kaiser Permanente rather than elsewhere? There's, as we know, there's a physician shortage in the country. Physicians really can practice anywhere. But one of the things that we really wanted to think about was the caring for the whole person. So certainly our compensation package is not just about the take-home pay and the benefits, but it's really about how can we really care for that whole person. So we've built a robust wellness program. We also have our own internal continuing medical education professional development department. So that provides coaching and classes to our physicians so they can improve their patient communication or their interpersonal communication with team members or their effectiveness in leading teams. So this is really a great part that helps contribute to our joy in work, knowing that wellness at work, only a third of it is around individual wellness, a third of it is like culture wellness, and then a third of it is about practice efficiency and So how do we really create a system in which it's a joy to practice? And then lastly, I think one of the key things that makes us really successful is our investment in medical informatics. So we've been on electronic health record for 20 plus years, but I would say that our electronic system is not just a health record, it's not just data keeping, but it's very robust point of care decision support tool. So for example, if I'm taking care of a patient and I see that they have a skin infection, I can actually type into my order entry area, cellulitis, and then I will get a list of antibiotics that are proven to be effective for skin infections. And then the computer will double check my selection against the patient's allergy list. So it's really effective evidence-based medicine practice that's safe for the patients. So we've built our medical informatics tool to be that robust and really help us in the day-to-day practice of medicine as well. And those are all the additional benefits that our clinicians get from practicing here. Keith mentioned in his introduction about our quadruple aim, that it's not just about quality care experience affordability, but that fourth part of the quadruple aim is around joy in work or physician wellness and sustainability. We really very much recognize that our own clinician wellness, resilience, our ability to support each other is what will enable us to be our best selves so that we can take the best care of our patients. So really that's, again, intentional. We have to make sure that medicine is sustainable in the long term, and that really when our doctors and clinicians are feeling well cared for, they're going to in turn then care better for our patients. So the next slide, and certainly cash compensation, benefits, all that practice support is great. But how do we really ensure good performance? And here is that for each individual clinician and staff, we also participate in what we call the incentive contractual payment, or the ICP. And so this is individual bonuses based on our collective efforts of how we achieve those regional targets for quality and service and financial goals. And so that this ICP is it's dispersed per employee, but it's based on overall performance of the group. And then this is above base compensation. So we don't do a holdback that you have to earn out, but we have a base compensation and then we have an additional plus side incentive. And then in addition to this, some departments are eligible for an additional incentive program that we call Pay for Performance. And we put this in place because as we started benchmarking our base salary to the national surveys, we noted that some of our departments were below that 90th percentile of the median. And so we, again, intentionally put this bonus program in place so that people who were below that 90th percentile, they had the opportunity to earn up to the 90th percentile. So this is our kind of shifting our culture to say, like, yes, we do want you to have more skin in the game and thinking about how you perform at your department level as well. So this is another great successful way of really helping move the performance over time. And then,
Ruth,
yes.
Ruth, give us a couple department examples of what would be included in the pay for performance component.
Yeah, great question. So, for example, surgical departments, one of their incentives was around on-time surgical starts, because the time in the OR and getting the patient ready, prepped in the operating room, starting on time, really has downstream impacts for the rest of the day. So for the patient care experience, for other care teams who are scheduled to use the same OR later. And so that was one of the ways that we could really drive performance, even though the physician isn't the only person helping get that patient ready for the OR time, but this really gives the physician the incentive to lead the team to make sure that we have on-time OR starts.
Thank you.
Question. doesn't that have potential downside to it in trying to get physicians to hurry their surgery?
Yeah, and so the targets are not 100%. Yeah, we set and say like, what do we think? How are we doing now, and how can we do better? But you're absolutely right. This would never trump safety, and it is not an excuse to cut any corners. So,
Thank you.
Again, and all these measures link back to the yearly high priority measures that the group is set, or the quality group is set within Northwest Permanente. So everything sort of ties back to what are the quality or service goals that we're trying to achieve. And then that ends up being the definitions and the metrics and the specs for both ICP and paper performance.
Great, thanks, Keith. Yeah, other questions or comments?
I think that one of the things that I just remember from my time was that these incentives were ones that were built while they were paid out to individuals. It was how well the group was doing, not as an individual. So as an individual family medicine physician, it wasn't what my particular numbers were. It was how well the large group, how the entire medical group was doing for meeting quality metrics.
Yes, that's correct, Tom.
The pay for performance is paid out individually.
Okay.
So that is a difference there.
Okay.
And again, this is all relative to salary. Both of these are very small. So for instance, ICP is typically 1 to 5% of salary.
Right.
Depends on the year.
Yes, and so even though it's small relative to salary, it still is a good motivator, and people do talk about it. So it helps us drive the performance. Yeah.
Super. Continue on.
Yes. Yeah. So then there's also our members do receive care outside of Kaiser Permanente. So if we are unable to give the patient the care that they need, we will refer them outside. And then Northwest Permanente really is responsible for looking at the outside medical costs and the provider payments. And so certainly we set up capitated rates for this alternative care, and also contract rates with quality incentives for mental health care, as well as for other hospitals or transplant centers. So we kind of use this same model around contract rates and then incentives to ensure that our patients are getting high quality care when we do need to send them out.
And there is a little bit of a complex interaction with the rate cap, because if the rate cap is in effect, then it's harder for us to develop quality-based contracts and incentives with hospitals around the state that aren't our regular hospital groups that we use most frequently.
Yes. Yeah, so I would say really, in summary, is that our incentives are aligned with really, again, our mission. And one of the sayings that we have around Northwest Permanente is right care, right time, right place. And really, again, our incentives align to those behaviors. So I think that's why, for me personally, it feels great to practice here. And when I graduated medical school, I was thinking about residency and where to practice. I was very conscientious in that I did not want to practice in fee-for-service, because I think whereas fee-for-service certainly makes sense, you get paid for what you do, the shadow side is that you get the more you do, the more you get paid, and that doesn't always align in the best interest of the patients. So I truly believe in our capitated system of payment. And thank you so much for your time today. And currently it looks like we have a few more minutes for questions. So if you have additional questions or comments, we'll welcome that.
Hey, this is Bill Graup. I just wanted to also hear a little bit about I don't know if you call it incentive programs, but just for doctors who want to go out and bring in newer techniques and stay current or get nationally recognized with, doing papers and stuff. With the data and the work that you're doing here in the Northwest.
So So, so I guess I want to make sure I understand your question, Bill. Just wanting to understand, like, if there's additional incentives for those physicians who
want to bring, who do the work of bringing in new techniques and new concepts and things that are being researched around the world, you know, bringing to this area.
Yes. Yes. So we do support our clinicians in that type of work. We have a paid sabbatical benefit, which is very rare among medical groups. And so that way our senior physicians can have paid time to go and pursue new skills and bring that back for the benefit of their department and our patients. So we have that program set up. And then as far as research goes, we have a partnership with our own Center for Health Research. So Kaiser Permanente Northwest has a robust research arm. And we do have physicians who have joint appointments between the Center for Health Research and our medical group. So they're all practicing physicians, and they have a joint appointment with CHR, and they're bringing in NIH grants and being part of clinical-based research as well.
Yeah, really pleased that with COVID, we were able to do one of the early remdesivir studies in our hospitals based on that relationship that our physicians had with our research center, who has a relationship with NIH, who is sponsoring the study, and similar vaccine trials going on as well.
That answer your question, Bill?
Yep.
Great.
Yep.
Anybody else? Ruth, thank you so much. We are, as I say, the board itself is going to be looking at the issue of equitable care this afternoon, and it's very possible that we will want to see more of what KP has been doing in this regard. And so if you don't have any other closing comments, or Keith or Sapari, we'll go ahead and move on.
Great, thank you.
Okay, thank you so much.
Thank you.
Yeah,
bye.
thank you.
Okay, so we are 3 minutes ahead of time, which is always good. And we have the next subject is MODA's value payment model. And that is with Bill Dwyer is going to be helping us understand that. So Bill, you're on.
Hi, everyone.
Hi.
All right, I've got some slides here that I'll go through, and hopefully everybody has them, but I'll just share my screen and we can walk through those. I've just got to figure out where monitor it is. There we go. Okay, so I'm going to go through some slides that cover the Synergy and Summit performance, and also a little bit of an overview of, since Synergy and Summit ended, what we're moving toward. And so the title on this is just value-based payment model performance. So just going over some of the details of what happened in our last model and then what we're going forward with. So first off, the first section will just be a review of Synergy and Summit and how it all turned out. So just as a quick overview of who was in Synergy and Summit, this is the count of unique member. There was a little bit of churn during the year, but this is the number of unique members that were in both the Synergy and Summit plans. So quite a few people, approximately 3/4 of the members were on Synergy at one point or another. Actually, this is OEB and PEB together. And then also just as a reminder, so Synergy and Summit basically covered the entire state, and it was this was a plan and network that we had quite a few different commercial groups, both large groups and small groups, and even some ASO or administrative services only groups in it. So it was not just OEB and PEB. So I will go to the next slide. So anyway, this is just an overview. The next couple slides, just to remind everybody what this was. So Synergy Summit was a 3B on the land scale. In other words, it was a shared risk model with upside and downside risk. There was a statewide network looking at both of them. There were some quality measures attached. There was a requirement to submit clinical data. So we get a lot of data for quality measures that comes in on claims, but there's some information that does not come in on claims, which is clinical data. For example, things like blood pressure test results, HbA1c test results. It's not on the claim, so we need to build additional links into our providers' EHRs to get that information. So that was part of Synergy and Summit as well. And then, of course, a robust provider reporting system so that providers would have some understanding into how they were doing on all these measures, and that we could help point out some opportunities where they could improve, or places where they were doing well or not so well. So that was also pretty important. So that was just a high-level overview. In terms of the shared risk model, this diagram sort of illustrates. There was some complexity to it. It was sort of a cube in that we would divide up the cost 3 by provider type. So, for example, in the Portland metro region, there was a fund for primary care that the PCPs would share in, and there was a fund for specialty care, which the specialists would share in, etc. There was a drug fund that all the different provider types would share in. So we, based on these 3 sort of intersecting ways of categorizing the providers and the regions and the costs, we came up with these budgets for all of these regions, and then you got to share in the surplus or deficit for the various parts of this cube that you had a role in. So it was that was what allowed us to have all of a significant percentage of providers participating in the network in the state of Oregon. The downside of this was it was a somewhat complex approach, but it did allow us to build the whole network out and offer a pretty compelling incentives to a large number of providers. Anyway, just some additional details. So the specialists and hospitals took a 10% withhold, and that was a risk contingency withhold. So if there was a deficit, then in the budget we would take that deficit out of their withhold, and if there was a surplus, then they would share in that surplus. So we calculated the surplus and deficit by each fund, and each one of those little cube blocks of the cube there, we calculated the surplus and deficit. The maximum loss would have been that 10% withhold. So so that limited the risk on providers. Primary care didn't have any downside risk, so there was no withhold on primary care. It was just an upside risk only. And that's sort of a theme that we've continued as well, and that's something that we pretty commonly see, is that often the primary care operations, you want to encourage as many of them as possible to join in, and so an upside only risk for primary care is the way that MODA has gone, and a way a lot of others have gone. So here, these were the quality measures. So we had 14 of them, and I've got the 2 columns there that indicate whether a data file was required or whether the measure was a bonus measure. So the data file required, to tackle that first. So those are all of the measures we would call clinical measures, all the ones where we're not able to report on that without a separate feed of clinical data from the provider's EHR. I guess the possible exception to that is the childhood immunization data. We do have a way to calculate immunization rates based on claims. However, for various administrative reasons, all of the claims data is typically not the best source of that, because there's so many places where a child can get immunizations that really the better way to do that is to get a data feed from the EHR, which is typically way more complete than the claim data. So anyway, so those are all those measures. The data file required was all the clinical measures. The way this incentive system worked is we would measure everyone on all of the measures except for those 2 bonus measures. And then a provider would either get or not get their incentive, and then there was some money left over because there were many providers that failed 1 or more measures. And so all of that money we put into a bonus pool, and then anyone who did well on the bonus measures got to share in the bonus pool. And so that was a structure that was attractive to providers because it allowed us to guarantee that all the best performers would get paid and that MODA would not be holding any of the quality money back. And so it was just a way to make sure that we were funding a certain amount of bonuses, you know, a fixed level of bonuses, and that those would all go to the highest performing providers.
So
Question.
Bill,
Yep.
this is Tom. I have a question. I heard another one also.
Yeah,
So,
sure.
Go ahead.
go ahead, Tom. Jeff's
Yeah.
annoying.
Yeah, my question had to do with these measures all aimed at primary care providers?
Yes.
Okay, thank you.
Yeah, it certainly is true that there will be some of the members that fall into the numerator and denominator of these measures that have a lot that are being treated by specialists, but for the most part, these are primary care measures. And as in fact, the majority of all quality measures are
agreed.
primary care focused.
Agreed. And when we on the state's health plan quality metrics committee, we struggled like mad trying to come up with meaningful statewide measures that were specific for specialty care. So do you have any that were aimed at orthopedists, cardiologists, oncologists, or was it really it really was primary, your efforts were primary care focused?
Yeah, they were primary care focused.
Okay, thank you.
And so we did not, we did not have orthopedic measures, for example.
Yeah. Okay.
But there's no question about it that some of these, like, for some of these, like, measures, you're going to have to, for cases where the member is not doing well enough to be in the numerator, some of those are going to require specialists to help out to get them in there. So I guess the distinction I'm trying to make is, yes, they're primary care focused, but that doesn't mean that the specialists don't also, they're definitely needed.
Agreed. Jeff?
So, Bill, my question is, how did you arrive at the 2 bonus measures? Why not 3 or 4? For example, there's childhood immunization and even flu immunization. Why would they not be bonus measures? So what's your rationale for the bonus measures?
As I recall, and I have to confess that this was quite some time ago, and I'm a little fuzzy on the details of why we did that, because that was several years ago that we made that decision. But I seem to recall that the adolescent WellCare visit, as an example, was one where we felt like there would be a lot of providers that were able to meet the minimum denominator requirement. And so that one in particular was one where we felt like everybody would be able to at least participate. Now, whether or not they achieved it, fine, but the thing with a lot of these measures is it was hard to include every single provider organization in every measure, because they just did not have enough patients to make their result credible. And so I know that was one where we felt like that would be a good one for the bonus measure. To be honest with you, I can't recall just what the rationale was on the depression medication when putting that in there.
Yeah. Well, when I looked at these, I go, all right, the WellCare visit, the doctor's got more control there. And then you look at depression medication adherence, and the doctor has little control there. So I was trying to figure out the yin and the yang of the thing.
Yeah, and you could argue that they have more control over the acute phase than the continuation phase.
Okay.
And the vast majority of depression medication is being prescribed by in the primary care setting.
Yeah. Okay.
Okay, onward.
Okay, so then, yeah, and I mentioned about so this is about the quality measure funding. I sort of just already talked about this. We had a total budget, and we just wanted the structure where we could spend that budget and make sure it went to the highest performing providers.
Bill,
So,
we heard that, you're going to be getting to it. I was just interested in, we heard from Kaiser Permanente that the incentive quality metrics for their incentive program were in the 1 to 5% of salary. As you go through this next one, just kind of give us a ballpark on what you view. Thank you.
Yeah, so our incentive was quite higher than that. So, so one of the I participate in the Primary Care Payment Reform Collaborative in Oregon, and the payment model that group has come up with, and we continue to advocate and talk about in Oregon is it calls for a level of approximately 10% of compensation to be allocated toward quality incentives. And if you look at our per member per month bonus, ours is right there. So primary care groups, there's quite a range in Oregon, but if you break down the spending of a primary care group, they tend to fall between, say, about $25 PMPM on the low end, up to $40 or more on the high end, but most of them falling somewhere in the middle there. And so the amount that we spent on our quality incentive was approximately 10% of what a primary care practice would earn on a PMPM basis. And so, but we felt it was really important to have two different incentives. And there's been presenters in the past in SEOW that have tried to discuss and bring data forth on the link between doing well on quality measures and overall medical cost. And that is really hard to prove. For some of the measures, maybe it's a little bit easier than others, but in general, I think it's pretty well accepted that high quality leads to low cost. But there are certainly some things where maybe having the higher quality might lead to increased cost. Part of the synergy model is the design of it was to provide a powerful incentive to not only do well on quality but also on controlling the cost. And so the other half of it was the budget-based risk model incentive, the shared risk incentive. And so that one also we paid approximately 10% out when all was said and done in incentive to help control the cost. And if you look at, so this chart, so this is overall on the two different incentives, how many providers participated and how much did we pay out. You can see that on the cost incentive, the numbers are significantly higher because that would include specialists and hospitals, for which, as Tom pointed out, it was harder to come up with quality measures for them. But in terms of overall magnitude, we felt like the design of this program was sufficient to the size of the incentives were sufficiently motivating that we got good buy-in. And I'll just go to the next slide, which has the summary of what the shared risk, shared savings came up with. And these numbers fluctuated from year to year, but overall, for the most part, the providers did well and stayed under budget, and there was a surplus more often than not during the years that the Synergy program was in effect. So what this chart shows is the different risk funds, so primary care, non-primary care, hospital drugs, cutting across the different regions where we had separate budgets. And so you can see there were some regions that, for the most part, all of the regions, there was a deficit in primary care, and that was to some extent planned. We just wanted to make sure we did not, because there was no because there was no downside risk for primary care providers, we felt like we encouraged and in no way were with going over budget on primary care. And so, but when you look at all the categories together, I mean, there were some regions that did well or not so well in certain of the categories, but overall we had a pretty big surplus. Actually, the next slide just is sort of a graphical representation of how that played out during the year. And maybe this is more detail than you need, but I thought it was kind of interesting. That what this shows, each line represents one of the risk funds within the synergy model, with the top line, the overall, just being the sum of all of the other ones. And it just tracks what the surplus and deficit looked like throughout the year. And so, primary care is pretty much a smooth line. We were just, just was a little bit over budget all year and pretty stable. Some of the other ones had a little bit more wobbling to them. There's one line on there that we didn't talk about, which is the orange one labeled Carve. So that's our carve out fund. And that one is all of there was a stop loss in the model where if a member had accumulated more than $100,000 worth of claims, worth of hospital claims, then we would truncate or cap that amount at 100,000 so that it would not blow somebody's entire budget if they had one super expensive member. But anyway, there you can see that this, just from the overall, there was definitely some nice surpluses in hospital and drug, and deficits in primary care, and which is pretty much what we wanted to see and what we were hoping to see. Is and the way you can sort of read this is a big investment in primary care in this case led to surpluses in hospital and drug spending. So I'll go to the next one. This is just by region, and as you saw from the first chart, there was some variability in how certain of the regions did and did over time, with the Portland region one that had the highest surplus, and Central Oregon did not do so well. In previous years, actually, it was a little bit of a surprise there because Central Oregon had earned some bonuses in the previous years, but they had some bad experience this time, and there were some other things going on there. It just didn't quite work out as well in this last year of the model. So this next chart is the summit. So we've been talking about synergy, and just as a reminder, so synergy was the western half of the state, and summit was the eastern half of the state. So this chart here just shows the performance of the summit model on the eastern half of the state. The funds that we in which we divided up the claims, they were slightly different for summit. There were some things going on in the summit market where we just in the discussions with the providers there and making sure that we had created our model to really meet the needs of the providers out there, which were different. We set up the model in a slightly different way. It was the same concept with sort of a budget cube type of thing, but just a little bit different way in the way we broke down the little sub-cubes of the cube, if you will. And the summit one that did not do so well, but again, it was in a similar way to synergy. For the most part, there were surpluses. Just in the last year, there was a bit of a deficit in summit. I want to switch over, unless certainly stop me. I want to switch over to talk about, so that was how well Synergy and Summit did. Now I want to talk a little bit about where we're going since Synergy and Summit ended and our new model and how that has been doing.
Bill, I do have one comment that
sure.
That if particularly as you talk about the new model,
okay.
the risk for incentive programs that apply to individuals or small groups is that unless you risk adjust, you have a strong incentive to move people who are at high risk and high cost out of your panel of patients. And when you risk adjust, you then solve that problem. But I haven't heard any word about risk adjustment. I don't need you to talk about Summit Synergy because that's gone. I am interested as you start talking about the new coordinated care model, the how you're dealing with the issue of disincentives to care for the more complicated, expensive patients.
Yeah, perfect. I've got that covered on my next slide, Tom. So we'll get to that on my next slide. So this one is just an overview of what the coordinated care model is. So we started on October 1st, and then all of the various alternative payment arrangements. We have capitated primary care. Not everyone has taken us up on that, but it's certainly available, and we're encouraging and pushing that. We've got 13 quality measures. We have a total cost of care incentive, although it's a slightly different structure than the last one we had. Members have to select a PCP, and the selection of the PCP is of pretty critical importance so that we understand who to hold accountable for their total cost of care and quality. And as a side element, all of our provider communications and reporting structures are based on that. So that is a pretty important element. And then just to get a little bit at, Tom, your question, and then we'll get more on the next slide, is just the design of this model was to offer the same premium for somebody who would go into the coordinated care model as not, but just offer better benefits. And we just felt like that was going to attract the kind of member that we wanted. And so I'll just go right into the next slide, and just right up on the top left there. One of the advantages of the new model versus our synergy is it does give us a better distribution of risk. And so one of the problems we felt like with the old synergy model was it just being a lower price, there was a perception that it wasn't as good, perhaps, and when members are going to select their plan, they wanted an expensive plan if they wanted really good coverage. And so equalizing the premium meant that we were able to attract members that had higher risk profiles than before. And so that's just one of the advantages. We felt like when you look at the average risk score of the members that are in the CCM plan, it's much higher than the average risk score of the members that were in the synergy plans. And in fact, the average risk score of our CCM members is higher than the average risk score of the people that are not in CCM currently. Because that's what you want. If you want to build all these incentives for providers to take care of all these people, well then if you but you just give them healthy people to take care of, you're putting an incentive on the wrong group. And so that was one major improvement that we made to move to the coordinated care model. And then to continue the discussion of how risk plays into it, just to move to the top right there, just a better connection of rewards to performance. What I mean by that is the synergy model had that complex cube, and we had all these budgets broken down, and all the providers were in these risk pools by region. But there were many providers that felt there's definitely trade-offs here. They felt like, well, it's hard to really see in that model how my own performance, how I'm getting paid on my own specific performance. And there was no risk adjustment in the budgets for the Synergy and Summit. And so the coordinated care model has an advantage that the way we calculate the shared savings, the surpluses, and how we calculate the targets and the actual cost is a risk adjusted model. So we calculate a risk score based on diagnosis and prescription drug history for each member. We come up with a risk score for each member, and then the provider is not penalized if they start off with a panel of sick patients. And so it does not matter. In fact, it's to a provider's advantage to have sicker members, because if you have a sicker member, you get a higher, then your target becomes higher. And so the way to win in that model is to do a good job of managing patients who had previous high medical costs. And that way you can show that, if you can hold the trend down or even reduce it, then there's a nice payout for you under the coordinated care model. And it's just an improved way compared to Synergy. And the second part of that is that we focused our coordinated care model. It's not a region-based model. So because of the what I'm going to characterize as the more accurate and more direct connection between a provider's own results and their bonus. Well, I guess that's what I'm trying to say. There's a more direct connection, and so it's just a more powerful incentive. So anyway, hopefully, Tom, does that answer your question on the risk, or did you have a?
No, that is exactly what I was hoping to hear, and if I had heard it before, as you were talking about it, you've answered it now a second time, but that's exactly the type of thing we need. So, congratulations, thank you.
Okay.
Anybody else?
Yeah, I've got a question. Back on page 13, you list capitated primary care.
Oh, this is wait. Let's see, page 13.
I'm just curious about capitated primary care in an open system. It just kind of conjures up memories of years gone by.
Yeah.
Go ahead.
And so having capitated, that's if I go, there's two in Oregon. There's definitely two things that have been part of prompting us to go down this path. I'll reference again the Primary Care Payment Reform Collaborative, which is strongly in favor of the moving to capitated primary care, and that work group is made up primarily of primary care groups, but also health plans, and there's even a hospital representative. Primary care groups have been advocating for this approach for some time, and there are many reasons for that. One is just so that they can be freed up to deliver the care in the most appropriate way possible without having to worry about how they were billing for something. And the example, I remember one time I was sitting in a meeting with some people from Salem Health, and they were describing why it was so important to them to move to a capitated model, and it was because they wanted to bring in clinical pharmacists into their care team, but there's no way for a pharmacist to actually bill medical claims. And so they did not have a way to pay for this person that they thought was critical to helping to manage diabetic patients. And so, but they felt like if you just, free us up from this, treadmill of trying to bill office visits and just pay us a flat rate, then we can go and hire these pharmacists, and then we'll do better on our, on our diabetes care. And so, similarly, there's other, just to have the freedom to do your treatment with a variety of different types of professionals, that not everyone has to be an MD that touches the patient, and then use all different methods of communication. All of that is made more simple by moving to a capitated arrangement. I will note, in addition, that the way we've started with capitated primary care is not 100% capitation, but rather allowing the primary care groups who were ready for it to select their option. We started out at only 20% capitation, and then we've been gradually increasing it as providers are interested. And so we've had providers that started at 20 and then moved to 40% or 60%. Now we have a bunch of them that are at 100% because they just appreciate the fact that there's a stable revenue stream.
Yeah, Bill, I would assume, though, when you say that, it is only for the primary care component of the total budget. The primary care are not getting the total, they're not getting a global cap for all
That's
care.
Correct.
Yeah.
Yes.
So I think that's one of the big differences between what happened in the 90s was where people got risk and it wasn't even in their sphere of influence.
Yes, and I'll even go further than that and say that it's not only it's just it's not global capitation for the entire budget. It's only the primary care spending that's capitated,
Right.
and it's not all of the primary care spend. It's only the what we would call the E&M codes, or the office visit type codes, evaluation and management. So things like vaccines and contraceptives, those would not be covered under the capitation agreement. We pay fee for service for those.
Okay, good.
Because
we have just a couple minutes left, so if we could move. Go ahead.
Just thank you that both of you helped clarify that for me. Appreciate it.
So let's see. Here I go. So similar to Synergy, we have 13 quality measures. Several of them are the same measures that we previously used in the Synergy model, and there's also, like the Synergy model, there's a clinical data component. So this part of the model is pretty similar in terms of its structure to what we had. I already talked. Actually, I don't even need to really go into detail on this because I already talked about how this works. I will just mention, though, that because of COVID-19, we're going to have some payouts on the total cost of care incentive, which is fine. The total cost of care incentive under this model is a budget-based model, and the medical costs are the trend is lower now than what it was, and we expect that a lot of providers are going to earn a bonus. There are some that are not going to earn a bonus, but a lot of them are. And I think this is my last slide here, just to show the early results. And this is how providers are doing sort of on a rolling 12 months. So this is not an indication of how they will do. I actually think it's going to get even better for them. We had, there were, actually, and there's the thing about the incentive is you do need a certain minimum number of members to get credible results, and that minimum number we set at 300. So there's a few hundred providers that wouldn't qualify because they're too small, and that's 13,000 OWEB members are assigned to those providers. But the majority of OWEB members are assigned to providers that do qualify for the incentive, and you can see there, some of them hit the target, some of them hit the maximum. But that number is going to continue to increase as we keep going with through the year, and we have the continued impacts of depressed utilization from COVID-19. So that's all the slides I have. I'll pause there, and I think unless there's any other urgent questions, we'll wrap it up there.
Yeah. Anybody, any SEOW members with questions? I had one quick one, Bill. When you showed number of providers, would that be a medical group, or is those individual physicians?
Yeah, that's a system. So it would be like the entire.
Good, yeah, because otherwise it didn't make sense to me. But with an entity, I can understand it.
Yeah.
Okay.
This is Ollie. If I could ask Bill just really quickly, related to the capitated primary care payments. OWEB have that legislative directive that we expend 12% of total expenditures on primary care by 2023, and we're always currently hovering right around that 12% range. Would the capitated primary care payments help us meet that every year?
I would say that it's, and in particular it helped because the providers that were on capitation, they had more stable revenue when primary care visits tanked during COVID-19. The main thing I think that's helping us meet the 12% is the fact that we're offering these additional incentive bonuses on quality and on risk sharing. And then offering what we call care management fees, which is some additional funding, in a fixed nature. So I guess the care management fees are a type of capitation. They're not replacing fee for service, but they're just sort of supplemental to help the practice build infrastructure. And so it's those types of things that are helping us to get to the 12%.
Thank you.
Okay. I have it down at 10:49. So thank you very much, Bill. That was very helpful. We will continue at 11 o'clock, and we're going to be having a presentation on the Lodestar program. So we will call it for about 10 minutes and rejoin then. Thank you all. Glenn, are you on?
Yeah, I'm on, Tom.
For our next section, who is going to introduce the people from Mercer?
I can introduce them.
Okay, so if you want to introduce the topic in a couple minutes,
Okay.
in about 2 minutes, I'll call everybody back to order, and I'll have you then introduce, and we'll go from there.
All right. Yeah,
Thank you.
I mean, basically what it is the IWG.
Right.
they
No, I
passed
remember.
this.
Yeah, I saw that, and I read the. I just wanted, in terms of logistics, I just wanted to make sure that you and I were on board on that. Thank you.
Looking pretty serious, Robert. You're on mute.
I'm just in my downtime. I'm just focused on this election stuff. It's just
oh God, that's a mistake.
Yeah, I turned it off.
I just need to tune out.
Let it go.
Turn it off. Turn it off.
Don't give me a restroom break then. And I'll be fine.
Sorry.
Robert, that's not downtime.
Yeah. Okay, we're gonna. It is now 11 o'clock, and we've got this is the next hour and a half or so for the SEOW's meeting. Glenn, you're going to introduce our next speakers.
Yes, we have James Matheson and Cindy Ward from Mercer, and they will be speaking about the Lodestar program, which has been discussed and recommended out of the innovation work group. So they'll be presenting on that. James, do we have you on the line?
Yes, can you hear me?
Yes.
Very good. And I'm a beginner on Microsoft Teams, but I'm going to click this thing that says open the share tray.
Yes.
And I'm going to share my entire desktop. And I think you'll see a little Mercer colorful balloon.
Yeah, we see it.
There it is.
I am not completely familiar with this group, so I should probably just introduce myself quickly. I'm an old, tired actuary from the Northwest. I spent a long time up in Seattle, and I got to work with Jeff a little bit during that phase. And right around that time, I moved to Oregon and became a remote telecommuter, which has turned out to be quite convenient during these times. I've done mostly public work, both on the employer side, and now I work quite a bit on the Medicaid side. And then I got to help sort of facilitate the innovation work group, which I considered quite an honor to work with that group and to then translate, integrate, and sort of help coordinate with the two consulting firms that support OWEB and PEB. In that context, the idea of innovation is always evolving. And we had some ideas that were smaller and more short-term tactical, and we had some ideas that were pie-in-the-sky wishful thinking, or potentially realizable with great effort wishful thinking. And this represents potentially realizable with great effort wishful thinking. It is an idea to set up sort of a PEB and OEB defined, prescriptive, value-based program where vendors help administer it, but we are not asking the vendors to do the same things that we normally have asked them to do. So it'll make more sense as we go forward. Please jump in or whatever. I'm going to be looking at what I'm presenting, so I'm not sure I'll see screen. So don't wave, just verbally jump.
Could Cindy take a moment and
oh yes, sorry.
Introduction?
Yes, Cindy, you go.
Hi everyone, Cindy Ward. I've worked with James for several years now. I am on our Mercer's clinical health and benefits side, mostly.
Cindy, I can barely hear you.
Is that better?
Yes.
Helps when you
Much
pull
better.
your microphone bar down. And
Good.
sorry, Cindy Ward with. I am a registered nurse by background. I've done both physical and behavioral health, and I've worked with James for several years now, supporting some actuarial work, but mostly doing Medicaid and other health plan design. And James came to me and said, you know, I've got this cool project that I'm working on, and I would just want you to think about if you could design anything from a member advocacy model perspective, and it can be all wishful thinking and everything that you would ever want to see. Wouldn't it be cool if we could build something like that? So that's what we've tried to do, is put something that we would put every single best practice that we see nationally and see if it could be something that could work for this project in Oregon. So very excited to share it with you today.
Thanks, Cindy. What I have in mind, remind me, are we on for an hour or a little less?
1 hour.
Okay. What I have in mind is to kind of prance through just a couple slides and then go to this interactive sort of document that we've tried to develop that will help, we think, let people explore the idea without having to read from the beginning to the end of a long tome. And
someone has, oh, it's gone now. I'm sorry. There was a mechanical sound that someone had. Go ahead. I'm sorry, James.
Oh, no problem. I do have a little heater in the background. If you hear it, I can.
Yeah, it's you. Is
it me? Hold on.
Yeah.
It'll be gone in a moment.
Okay.
So a few slides and then this interactive thing where we'll go a little bit deeper. You'll hear a couple things twice just because of the way that's sequenced, but I don't think that's a bad thing. The idea was that this program would be alongside a complementary alternative to current offerings. So it's not designed to replace anything that is in the PEB or the OEB side, but it would be more like the prescribed by the purchaser plan as opposed to the managed care entity's design. We would ask them to do what we want with respect to payment and advocacy in a more direct fashion. The goal is to have strong payment methods, and you'll hear a lot about that in terms of sort of a reference-based payment, but not to maintain straight old fee-for-service. And then the part that Cindy championed was really the integrated, non-frustrating member services interface that you'll also hear quite a bit about. From a hard numbers perspective, there's a lot about paying different and paying with better incentives and a guaranteed budget. But from a softer side, the intent is that the members would be completely, we would get rid of what we are doing now. I think we all know that. When you go to a chiropractor, you don't need surgery. When you go to a surgeon, you do need surgery. We would try to integrate all the best practices from medical opinion and referrals, essentially creating like a statewide center of excellence where the member advocates would know which providers would be the best for you and would help you evaluate your medical condition and options. I'm guessing this group has looked at this continuum a bunch, but I'll just pause for a minute to see and make sure I'm correct. Okay, I'm going to take that as a yes.
Yes, we have.
Good. The world is all staring at this, and we're all talking about how to get from 3A to 3B or whatever. I will confess at this time that I am completely burned out on shared savings programs. And jumping over those shared savings programs is, well, I have one idea that we could talk about. If you really want to talk about shared savings, I will not leave the room. But our goal was to actually, in this sort of wishful thinking, jump straight to something that meets the global budget, that is got quality integrated, and you'll hear a bunch more about that. We also circled the foundational payments for infrastructure and operations because this would be a substantial change. I'm going to go over these pretty quickly because we'll hit them again. We have this advocacy-based member experience I've already mentioned. On the payment side, we have the idea of linking payment levels to Medicare, but adding quality payment as well as sort of a fee-for-service architecture. I'll say more about that. And a budget adjuster so that all those payments would be monitored, say, quarterly and adjusted up a little bit or down a little bit if the system was exceeding or coming in under budget. The idea for now is that this would be serviced with 2 vendors or perhaps one mega wonderful vendor, but that one would be the pillar 2, 3, and 4, payment, quality metrics, budget adjusters, big network contracting, payment processing, data aggregation, and quality scoring. And the second vendor would be the softer side of member advocacy. I'll just go through this. This is, I guess, obvious. The members are happy. The incentives, and a part of this is to have providers willingly think it's a good idea. Now, some of your questions may be, will the providers want this system? And I think that the stakeholdering approach and the design approach will need to target that. We'll talk more about how quality and value are integrated and how data drives the platform. And again, one of the things, given we're going to innovate, we just decided this thing's going to meet the 3.4 budget target. I'm not going to go through this one too much because I think it'll come out during the rest of the call, but this is envisioned as an instance, one way, a prescriptive way to kind of cut to the chase and get to the end game of what Senate Bill 889 is looking for. And with that, I'm going to take a minute for any questions, or I'll pause for a minute, and then I'm going to go to this link that is the more detailed information.
This is Tom. When you describe that group, that the entity or the vendor that does pillar 1, 2, and 3, that sounds like a health plan.
Yes, I think it's a health plan, probably in ASO, not insurance mode. It's a health plan that is really ramping up their technology, data payment systems. And I think that it is in the realm of a health insurer.
Okay, that's good.
This was our idea, since it's the innovation work group, to do things a little bit different. And it's one of those deals where you have like an outline and you can drill in and back. So I could go to different sections and you could guide me. Like we could start right now. Someone could say, what if you click on pillar 1, or what if you click on here? Or I could try and pick some of my favorites. I think the most important thing is that we're trying to leave a little bit of fee-for-service in place. I kind of want to say this right. Kind of take it to like 70% fee-for-service and 30% quality-related, and those numbers could change. But there are some benefits of fee-for-service from accountability, data tracking, encounter, data understanding. So this is sort of hung on a fee-for-service architecture, but then with quality-based payment that we'll talk about on pillar 3, and this budget adjuster. I'm just going to take a minute. I see the old presentation is still showing up on my screen, and it's distracting me a little bit. Okay, I feel better. Why don't I go through the pillars to start? In the executive summary, we have the 4 pillars, and I've already mentioned them. And Cindy, I think that people would benefit from you taking a minute, and you can tell me where you want to go, but would you like to expound on the advocacy-based member experience?
Sure. I think we can start with the nutshell. We started with, if we could really build something that was truly member-centric, that wasn't something that we would typically see done today, knowing how complex the healthcare system is, what were the types of supports that a normal member or someone with high-risk needs member might need? So we thought about it from a continuum perspective. Everything from a member that needs very limited support, maybe that's limited support because they don't have a level of complexity with their healthcare conditions today, or maybe they're a very digitally savvy member. So they want to do things that are much more interactive from a technology perspective, and they don't need hand-holding, all the way to the member that really did have complex needs or difficulty navigating the healthcare system that was attributing to some poorer outcomes and might need a lot of support and an array of different types of supports. So these are the sort of core competencies we would expect a member advocacy vendor to bring to the table. Being able to assist with wellness activities, member education, finding quality and steering members to quality providers. So this is really an array of understanding who the quality providers are within a network, having a methodology to identify them, and not just reward them, but then steer members to those more quality providers. Think centers of excellence is an example of a quality provider that if you're the best in the state at doing total knee replacements, ideally that's where you'd want to send the vast majority of your membership. Understanding benefits and out-of-pocket costs. I think if you've listened to the news at all in the last couple of months, the idea of surprise billing and not understanding what it's going to cost you to access your healthcare benefits is a big concern for people. So we looked at this member advocacy model as a place where you could get that information. Transitioning home after a hospitalization or any type of surgery, outpatient stay that required you to have some needs and some needs met at home, that would be part of the advocacy model. understanding your conditions and treatment options, getting second opinions. As James noted, sometimes when you go to a surgeon, suddenly you need surgery for something that maybe could be treated less aggressively. Managing service authorizations, so not having delays. If I truly do need carpal tunnel surgery, find me the best provider, get that approved. Let's get that treated as quickly as possible. We've woven in health disparities and social determinants of health. We know that these are things that drive poor health outcomes. We know that there are health disparity issues within the state, and we would expect that the advocacy vendor would be aware of these and able to tailor their program to the needs of the Oregon membership. And then ideally, holistically, we're not treating people in silos. If you come to us with physical, mental health, and substance use issues, all of those things could be managed and fully supported by the advocacy model that we're building. If you skip to the advocacy team, James, I think this gives a little bit of a picture. Yeah, what we looked at were some vendors that are doing some of this. They're considered like concierge member advocacy models, but there are companies out here that are doing this. And typically the way that they set up their team is in this sort of pod model. You've got an advocacy lead that is the person that is the primary point of contact for a member. It's the person that they deal with. They don't necessarily have to interface with everyone else that's on the team. But that advocacy lead has access to an array of support members on their team, from social workers to clinical support and behavioral health or substance use professionals, and then some access to a physician when you need that higher level of clinical expertise. So we modeled this after some of the better practices that we noticed some of these concierge member advocacy vendors doing. And really the point here is that for the member, this appears seamless. They don't necessarily have to see all of the work that goes on behind the scenes to support the array of things that the advocacy lead is supporting. But in order to make sure that the advocacy lead can do all of those things and be everything, we know that there needs to be a support team behind them. So this could vary. We're not married to particular licensures or particular requirements or being very prescriptive in this area, just knowing that we would need an array and a team that could support all of the things that we're expecting the member advocacy model to support. And it's really that holistic approach. It's one-stop shopping for me as a member to get any of my healthcare needs or social determinant of health needs met through one point of contact. I think the other thing that is, if we go to the member support levels, we really started to contemplate the different levels of need. And we haven't built this component out as broadly as we will, but we know that there's a lot of technological support tools that are being developed out there. Everything from diabetes management to online member directory that I can search on my phone. We wanted a member advocacy group that didn't just focus on the people in a team, but really was bringing forth some of those AI and great technological tools that are happening in the market, so that to the extent that members could self-serve and download apps or do their own supportive work, find a quality provider, the member advocacy vendor would have this level of expertise or could partner with someone who had this level of expertise to bring it to the table. But we wanted something that was, if we were going to be truly innovative, if you have a technologically savvy member component, that they have every tool that they need in order to access their healthcare, their benefits, and find the right provider in a technological solution, all the way to the member who that's not their area of expertise. They need somebody truly to handhold them and walk them through the process because of the level of complexity of their needs, or just their inability to navigate the healthcare system effectively. So I hope that gives you a sort of an overview of what, when James said, wouldn't it be cool if this is all of what we propose could be really cool if all of my needs could be met as someone who accesses healthcare. Anything that I could think of that someone might need could potentially be met by this advocacy model.
Thanks, Cindy. Let's pause and see if there's comments or questions before we move to pillar 2.
I'm sorry, go ahead.
Well, I was just going to say, James, this is Ollie. I think the members of SEOW are probably somewhat familiar with a lot of these concepts through the MODA 360 program that they're rolling out, and as well as Kaiser actually in their delivery system. So we're not talking about a huge reach here. Just wanted to add that concept.
And this, go ahead. I'm sorry.
No, go. No, I was just going to agree.
Go ahead and respond to Ollie.
Oh, I was simply going to agree and say that, some of these are broader trends and we are making some progress in this direction. So it's more of a continuation of a theme.
And my question is, this is Tom, how you think these services are, or if there's experience out there, whether or not it is best done by trying to take these issues and embedding them in the actual delivery systems versus it being something supplemental that a vendor or a health plan would do.
Gosh, that's a really good question. It's definitely not something that we have come to a overall conclusion on. Overall, what we know in the market is the closer that this type of support comes to the member, the better effective it's going to be. So when we have care management or care coordination programs, for example, that exist within a primary care provider's office, that's going to get access probably a lot more readily. That's the trusted relationship, and it's at the point of access to care.
Okay.
But one of the things that we do know is this is probably a heavy lift at the provider level area. Where the market is right now is that there are vendors that do this well that sort of attach on to a benefit.
Okay, so this is Robert. I'm going to have a basic question then. So if this is similar to what MODA's doing with their 360 program, is this part of Lodestar integrated with the MODA plan? Is it parallel? Is it supplanting it? I'm just not sure.
Yeah, I'll try and take that one. MODA's down the road on doing some of this. The idea was that the more traditional managed care plan environment would sort of evolve in a flexible way, like when we asked them to do 30% of payments through alternative payment methods by year 2022, or like that sort of flexible, please steer your program toward the healthcare land continuum over time. And then the Lodestar was supposed to be more of, let's do this now and get there sooner. So in the MODA, and I'm not an expert on OEB and MODA, but I've become a little bit more familiar. I would say that MODA would be eligible or would consider whether they wanted to bid for a Lodestar program, which would be a broad network with prescribed payment levels by the programs and all the stuff we're going to talk about, including a strong member advocacy focus. So I would say they would be one of a potential list of suppliers or bidders for this program. And to the extent they've already made big steps on the member advocacy side, the bigger differences might be in the payment technologies.
And we have a half an hour left or thereabouts.
Okay. Let's move to the concept of Medicare linked payment. I'm going to pull up, this is a chart we did quite some time ago on the innovation work group, and it shows what percent of Medicare is being paid by the current health plans in the two programs. The Kaiser bars are always challenging in our program to interpret. So let's not focus on the outliers, but more on the general concept that there's a different percent of Medicare being paid for physicians than there is for lab and radiology or DME. This is the medically administered drugs, so it's like Part B it's drugs that are on the medical benefit, not retail. You'll all know that we have in the state put hospital at 200% of Medicare, and hospitals not shown here. This was a study of the other service types. So the concept is that we would develop a payment protocol where, informed by current spending, the provider payment would have a underpinnings of a fee-for-service at a percent of Medicare as sort of the starting point. I'm looking for something to show you. For example, if we had primary care physicians or physician groups, we would start with some level, and this would be a bunch of work to come up with the level of percent of Medicare payment, and we would then have a quality score, and the quality score would adjust that percent of Medicare final payment. The thought here is that different quality measures would be more fitting for different provider types. So for example, a specialist might have more of an episode-based quality measure, whereas a primary care doctor might have more of a population-based prevention quality measures. And the target would be of 30% payment linked to quality. The thought is that the percent of Medicare would allow us to consider and phase into things that might be policy changes from current. We'd maybe start with current, but there are some thoughts that Medicare is not perfect and that primary care payment may be low relative to specialists. So we could, in this model, use the architecture to increase the primary care payment. We've talked some about site neutral payment, and I think you all probably have heard of this a little or a lot. But again, because of the underlying architecture of the percent of Medicare with adjustment factors, this would be a platform from which you could implement site neutral payments. And I like to just point out that by maintaining some of the fee-for-service architecture below the surface, we'll have solid data capture. Now we need more kinds of data. We need different social determinants data, but one of the risks on some alternative payment methods is that you lose the ability to know what encounters happened with what outcomes. On the quality related payments, I guess I've mentioned a little bit already, but the concept would be to probably start in year one with an assumption of high quality, and then over a couple years phase into like maybe plus or minus 7.5 and then plus or minus 15, so that about 30% of payment would be based on a provider's quality score, and there would be the 70% fee for service level. Now this is just a idea. This could change. This could be 50-50. This could adapt to the times where maybe we need to build in some capitation to this system. So maybe the 70% fee for service is half prepaid and half per service. The concept is that that vendor that does the percent of Medicare and the quality and the budget adjuster would be a perfect platform from which to accommodate, adapt, and handle things like pandemics. I guess since we're going to want to leave a little time for questions, the concept on the global budget, maybe I'll just go back up, and I think I have a little tiny example here. Kind of a simple concept. If costs are running a 0.5% high, everybody gets a 0.5% haircut. On the upside, if the incentives in this program tend to reduce unnecessary care, and if we're beating our 3.4% budget, these adjusters could go higher than 1, like in this quarter 3, payment could go up. Or I'm sorry, quarter 2, payment could go up. So the concept of a quarterly test on whether we're meeting budget or not, and an adjustment of the payment levels broadly to meet the budget is integral to the design. In preparation for questions, I will say that this is an early design. We've had sort of good results. People have been interested enough to keep asking about it. In terms of making it real, it would take some time. And this is one picture of how that might play out. Because these are pretty big ideas, we thought that an RFI would make sense, both from a vendor perspective and to just get the information out more broadly about a potential idea for PEB and OEB. So the current thinking on the innovation workgroup team is that we would maybe shoot to get a RFI out early next year. And then if someone said that our advocacy model was good but could be improved with A, B, and C, we would listen. If someone said, oh, your payment structure is good, but you need a different version of DRG grouper than Medicare uses, we would listen. And we would take what we got from the RFI, maybe have a bit of a feasibility go, no-go decision and develop an RFP, and then leave a good long time for implementation because of the significant amount of change. I think that's a reasonable overview for the Lodestar concept. It is fleshed out enough to be able to talk about. We tried to put it in context as sort of the other side of the managed care plan, so a complementary alternative, sort of the company plan. One benefit of that I didn't mention is that it will give the program something to test with. So if you have your broad Lodestar plan and do risk-adjusted per member per month comparisons to your Kaisers and Modas and Providences, you would have sort of a new basis for comparison. And with that, I think I should stop and ask if there are questions or comments or concerns.
Okay, SEOW members, jump in.
Tom, I can probably get started a little bit. This is Ollie. It sounded okay.
I'm getting reverb, Ollie.
Okay. Try again here. I think when we first set out looking, as the innovation work group at the pie in the sky, as described, it was really looking at a sustainable model that would take all the legal directives that were under, like the 3.4% annual cap, the 200% hospital payment cap, the 12% expenditures on primary cap directive, the 70% value-based payments by 2024, align quality metrics into a sustainable model that in the future would guarantee that we stay at the 3.4% cap every year and not have to sacrifice level of benefit to reach that cap.
Yeah.
So that's kind of how this all started. And it's not a guarantee that we'd have to go out for a medical RFP. There is, potential of looking at other options, but obviously it's a huge change. So
yeah, it seemed to me that all the different elements there involve. I'm going to go back and my experience. I had 9 years of being an operations medical director for Kaiser Permanente Northwest. And during that time, we had not knockdown, drag-out fights, but a lot of work trying to pull all the elements of the delivery system together to come up with a coherent plan that met the needs of our members in terms of cost, quality, and service. And that was within essentially one organization. The idea of trying to pull that off in a statewide effort with multiple competitive entities seems to be pretty Herculean, and the people who have the best experience with it are the Modas and the Providences and that are out there now. So the idea of a vendor who is not one of the health plans being able to come in and duplicate all that in terms of infrastructure and contracting and member outreach and all provider relations, all of that seems, again, pretty Herculean. Now, the issues that that are raised in Lodestar in regards to the member advocacy work, the some of the payment methodologies and the like. I mean, I think those are real, and that's the reason that I think Lodestar has gotten as far as it is. But it's hard for my vision is too narrow. It just seems awfully hard to have that work not be done by the people who have been doing it for the last multiple decades.
I think that's a very insightful comment. And I have one interesting piece of optimistic data to share. When we started the innovation work group and we started working with the existing plans and saying, hey, can you just let us know what % of Medicare you're paying? We really anticipated that it would be quite a challenge, and it might take a couple of months for us to get reports back on what % of Medicare they're paying for hospital first, and then we did the other provider types. I was blown away by how receptive, responsive, and quick the current carriers were able to reprice everything at Medicare and shoot out a %. It was brilliant. Any other comments?
Just so unfortunately, when I was doing the pre-work for the meeting, I didn't click on this link, and I've been popping around the website looking through this. Sadly, my first gut reaction was, oh, no, right? When I look at the business model here, and I'm trying to find a pathway through to really digesting this website now, and it's a struggle right at the moment. Right? Basically, it's just a foundation of Medicare, bringing Medicare in, and without any supplementary work that Medicare demands. Medicare is based around a certain segment of the population, not the total population from zero to the end. I'm struggling, but this needs to sink in for a bit because I didn't hit this website with all this extra information.
Okay. We think too that it's quite a big ask. The goal would be to use Medicare, the strengths of Medicare, but not their payment levels. Maybe borrow a little bit of their QPP and MEPS quality kinds of things for some of the value-based purchasing in a somewhat fee-for-service environment. And then there are things like the MSDRG grouper that are just wrong for a different population. So some of those just become very technical details that you would probably need to crosswalk from the MSDRG to the APRDRG. And these ideas are simple in some ways, but to execute this program would be a very heavy lift that would have to be taken quite seriously with a pretty good batch of resources and a pretty good timeline.
Jeff, you have been part of the innovation work group since its beginning. Could you give us some of your thoughts?
Like Bill, I kind of struggled at first, and I've kind of settled on this as a framework for us to measure the progress that we're making in terms of delivering care, or facilitating care, I should say. So when I look at it as a framework, and as opposed to a product, it kind of helps me. I know there is sensitivity about being viewed as a Medicaid or Medicare style product, but I think that's really mostly driven by just an available database, not necessarily that we're trying to emulate Medicare or Medicaid. So I'm liking this as a framework, and we're going to hear more about this or complementary material at the board meeting. So onward.
Yeah. Robert, your thoughts?
I have a better concept of, the sequencing. At first, I thought this is just, how is it integrating with what the two providers are doing? But I see it as what Jeff said, as a framework for the future. Still need to wrap my head around, some of the graphics in there. There are a lot of things that, from my perspective, I didn't immediately grasp. So I've got a lot of learning.
Could I
think if it toned down a little bit, sorry, Jeff. The payment thing is just driven by the foundation of Medicare percentages too much, because I don't think that's really the foundation of what Jeff is describing. And so it kind of leans in when you look at the payment model as that is the total foundation of everything. And it's maybe from Jeff's words, it's not. And the material on the website can be toned a little differently.
When I first presented to the innovation work group, we had a couple slides that I thought were super powerful, and I'll get those out to the group. It talked just about the variation in provider payment in the commercial market versus Medicare Advantage. And one of the benefits of having a reference-based program and using a big reference like Medicare is that you can reduce sort of random or wild variation in payment to have something that's just a little more rational and a little more transparent and a little bit more able to make decisions based on.
I wanted to add that I think it's always helpful for us to have a vision to work towards, and it can be the statement of that vision is malleable and can change over time. also want to say I was really heartened by Cindy's opening comments about the member experience being so front and center in terms of how we look at this, especially in today's environment of adverse, I'm losing my vocabulary at the moment, but unintended consequences, member support, all that. So again, looking at it as a framework and on an aspirational basis, I think is very positive for us.
I'm interested in getting a sense of what our health plan partners have thought about the principles, the elements, the use of the Lodestar work as a framework, as compared to have we been able to start collecting their feedback?
Not formally.
More informally, yeah.
Yeah. Okay. So that it would be very important. I think it'd be helpful to be able to start getting that. And I don't know, Jeff, if you look at that being something that would be part of the innovation work group's effort, or whether or not we should be doing that through SEOW.
As regards to OWEB, I think it's falls within SEOW's purview.
Okay. All right. So what I think I also didn't, when I looked through the information, wasn't smart enough to figure out, oh, I got to go on this link and it's going to give me this treasure trove of information. So I have some homework to do also. And I think we need to identify out what are the kind of key elements, and start exploring them and seeing which ones, if maybe all of them, fit into what we're looking for in regards to the future. But it's a lot of work to do, and I think James has acknowledged that in his in the time frame.
Yeah, it is a big idea and a lot of work, and I do think I heard some interesting ideas there about the framework concept, the measuring stick concept. You could take a couple of ideas like this and evaluate existing alternatives. We thought that good ideas do get some momentum, and this one has a little bit, but I think the RFI would be a way to find out whether it has enough. And if the RFI goes out, the provider community might have some strong opinions, and the health plan community will either see it as an opportunity or something that they're not interested in. And I think we would learn a lot just by through looking for those potential vendors. We will get more than potential vendors. We'll get a ton of feedback.
Ali, a question for you. We were able to move hospital costs to the 200% of Medicare through legislative action. Do you anticipate, if this is the direction that we want to go for both OAB and PEB, it would require legislative action?
I don't know. I've said that it would be great if this were something that providers found acceptable or favorable, but we don't know that. There is an issue with having critical mass to do something this big. And you're two big programs with PEB and OAB together, and you may have that critical mass, but I think that's another one where we would want to test the water and see if that is possible. Legislation wouldn't be bad, but I think it would be better if it were more organically, contractually based.
Ali, your thoughts?
Yeah, we do have a legislative concept out there that would allow for FNOAB to have expanded procurement authority. What that really means, we're not sure yet, but it's just, RFPs can, as this group knows, takes, a year and a half to 2 years. So to be a little bit more flexible and maneuverable would definitely help. But it's kind of, I don't like the odds on getting that through. So I agree with what the group has said. But, the current carriers are even include Providence in there from PEB with Moda and Kaiser, the 3 most innovative plans in the state, and you can see they're moving on some of these concepts that have been discussed in the IWG, and so there's a lot of potential there. And again, I think it's something that we started looking at as a sustainable system, is how to get our own statewide PPO plans and some of that, the costs that are really difficult to control. So that's where it kind of all started.
Great. Thank you so much. That was good perspective. We're approaching the end of our hour on this subject. Any last comments from Cindy or from James?
No, nothing really. Thanks for having us. And
yes, thank you.
Do click on the link if it's fun, and don't if it's not.
Oh, definitely will.
Okay, thanks.
Okay, any other comments from SEOW members, or can we move on to our next topic? With that, we'll move. Okay, so our last topic is a update on the ACT program. That's the additional cost tier program, and I have it that Brad is going to take us through that section. Brad, you on?
Yeah, I sure am.
Thank you.
All right. So in theory, I think that you guys should be able to, go in and see my screen right now. Is that correct?
It's on.
All right. So we're attachment 6, and today we're going to give an update on the ACT program. Recall that we looked at this first back in late 2019. We did a revision and an update in early 2020. So while there's a lot of material here, the group has seen it before, so we may be able to move through just a little bit faster. So a session or two ago, it was requested that we update this for the 18-19 plan year. And so we'll kind of just walk through and see sort of how that's changed and what the overall impact has been. So first of all, we're going to take just a quick overview of the program. Then we'll take a little bit of a deeper look at the utilization impact, and then further impact of the PMPMs, and then maybe take a really quick look at copays. All right, so recall that in 2010, we did create this additional cost tier really to help our members stop and think, via additional cost share about certain preference sensitive procedures before they had them done. So this was really implemented in 2010-11 plan year. You can see we've really got a number of different pieces. We've got knee and shoulder surgeries, we've got hip and knee replacements, spine surgeries, our kind of advanced radiology, sleep study, and upper endoscopies were the core ones. And we added a few a little bit later on, but those were the key pieces in there. All right, so the next couple slides really briefly describe the carrier procedure management processes. We know that MODA uses national guidelines for some of these procedures, and they also use some prior authorization and medical necessity review. Kaiser, really relies mostly on their established clinical practice guidelines. Important to remember that the ACT does not apply to the Kaiser plan, but they were included in previous versions just for comparative purposes to see sort of how the trends were performing relative to the MODA ACT program, kind of just as a benchmark or just a comparison point there. We are in the process of updating the Kaiser data. We ran into a few hitches with some of the data that we saw and some of the changes. I will tell the group that some of the data we saw from the prior analysis, where we saw some unusual differences, particularly in the magnitude of some of the utilization pieces, were explored further by Kaiser, and they found that they had misstated some or double counted some different procedures due to the way that their claim system records. So we're in the process of working with them, making sure that they are coordinating with MODA to make sure that they're on an apples to apples basis. And I don't know if we really need a follow-up presentation for that, but we'll provide that information as a follow-up via email when it's available. All right, any questions before we dive into the little bit deeper utilization data? Okay, so it's going to be a similar format. Recall that we had looked at data initially from 2008-9 plan year to the 2017-18 plan year. You'll note that down in our table now, we're looking at 2008-9 through the 18-19 plan year. In general, not a lot of changes in there. Certainly our first year impact didn't have any change with this update. Still had a material reduction in our utilization compared to both our prior year and the book of business. And then again, not a lot of change in there. We did see some ups and downs as we introduced the 18-19 data. There was some variation in volatility, but in general, we saw some procedures that increased and some procedures that decreased. Overall, I think that we have the same conclusion, which is a sustained utilization drop, but little incremental trend reduction, meaning that the utilization has trended similarly from the post implementation years for OEB and the book of business. Now, I will say that it does vary by procedure. We have some procedures that are higher and some that are lower in general, but overall, those average out to very similar, although a little bit of a difference in there. So OEB being just a little bit lower, maybe 0.1% to 0.3% from a trend perspective. So. All right, and we've got the table just really shows the total, pre-implementation all the way to the 18-19 plan year. So that does include that first year drop. So we can see that in general, we are looking at more favorable trend results in there. I think before we leave that, I kind of just wanted, I did a lot of distilling down and, really kind of the story on this. We did see favorable, lower MRI experience from utilization, but it was offset by higher CT utilization. We saw lower hip replacements, but they were offset by higher spine surgeries. Knee arthroscopy and endoscopies had really very little to no variation or difference from book of business. And we did see some more significant difference in knee replacements between the OEB and the book of business programs, and a little bit with shoulder arthroscopy and sleep studies. So that was kind of the big driver on a kind of looking at a multi-year, 7-year study on those. We saw some ups, some downs. Generally, we saw different categories offsetting each other, but did see some small, very small, but some incremental change in there. All right. Any questions before we dive into the details?
Yeah, this is just showing the trend, right?
This that we're looking at right now is just the utilization trend. So change in utilization over that period. And we'll get to the PMPMs in just a little bit.
Okay. Is there any reason to believe that we're squeezing the balloon into another area? So in other words, we're slowing this down, but it's manifesting somewhere else. I mean, you mentioned MRI and CT.
Mm-hmm. Yeah, I think that they're probably, you know, if we go back and look at, that's a really good point, Jeff. If we go back and we look at, you know, some of the copays involved in here, you know, and we see the MRI and CTs, they're both at $100. So I would say from a program perspective, I don't think there would be any, you know, motivation or any drive to shift people from an MRI to a CT, because the cost sharing under that, you know, additional cost tier is the same. So the same additional copay in there.
So this suggests to me that the original purpose of the ACT is still in play here. It's helping.
I think so. Yeah. You know, we did see a pretty big drop. If we dive into some of that detail, you know, we did see a drop in most procedure categories over, you know, during that first year. We can see that in the 9-10 plan year, for example, as we go through these charts, the OEB specific data is a combination of the purple line and the triangle, and the book of business data for MODA is the little dots with the black line. And we can see that here, you know, in that first year of implementation, we saw a very large reduction in utilization for the OEB plan, went from 76 per thousand all the way down to 67. So pretty strong drop. It's worth noting we did see a strong drop in the book of business, although not quite as much in the prior year. And then, you know, we've seen some subsequent growth through there, where we ended at the 17-18 plan year. They were almost equal. And in this particular case, the OEB experience has outpaced the book of business experience for the 18-19 plan year. I do think it's worth noting that as we look at one additional year, you know, that's probably well within reason of normal variation that we would see for utilization of a single procedure in there like that. But generally, you know, in this particular case, if we were just focusing on the numbers, we can see in the chart below that the book of business trend since implementation has been, in fact, a little bit lower than the OEB trend. So kind of pairing that, moving to the MRIs, you know, we can see a similar type of pattern in here where we had a pretty big drop, not quite as significant, but a fairly large drop from the 9-10 plan year to the 10-11 plan year, which was implementation. And since then, we've seen a little bit of bumping around. Some years were very close to book of business, some years were further apart. But generally, we can see that we've maintained the gap there. And in general, it looks like the OEB plan has trended lower than the book of business trend from a utilization perspective. So those are examples of where, on the one hand, it looks like there was some advantage. On the other hand, you know, maybe not in here. Jeff, did that help to answer your question a little bit?
It does. Thank you, Brad.
Okay. Any question on the advanced imaging data that we just saw here?
This is where it all began, was concern over MRI use.
Yep.
Yeah, and yep. This is Tom. So there's two different issues that are going to play. One is with the ACT. One is the actual increase in copay that we receive, or that MODA receives, and the other is the change in utilization. So as we go through this, you know, not for each individual, but it would be, and I reviewed this, but it was a couple days ago. I don't know if we've come to the conclusion that which of those two elements, the additional copay revenue versus the decrease in utilization, has the bigger impact, and what percentage, how that's divided.
Yeah, I think I would, in general, for these type of procedures, I haven't looked at the specifics around them, Tom, but I would say generally we see change in utilization having a larger impact than change in cost share, even for these larger, some of the $500 copay pieces. And part of the reason for that is that sometimes, particularly if members are in the richer plans, we do see them hitting their out-of-pocket maximums, and so in some cases these higher copays would not, at the end of the plan year, by the end of the plan year, would not necessarily really make a difference. So that may be making more of a visual difference than an actual. And I can't remember the exact numbers. We had Moda run some numbers and take a look at that at one point.
Okay, great.
Yeah.
Speed
but in
along.
general, I think we would. Yep. All right. So hip replacements. We did see in the long term, we saw some great improvement from OEB versus the book of business. And you can see this is an example of how 1 year's experience can lead to quite a different change on our overall evaluation. So in this particular case, we did see the book of business had a very steep increase from the 17-18 to 18-19 plan year, and the OEB plan had a decrease. So we've seen across the years, we've been, the book of business has been generally under. In the current plan year, we did see a significant closure of that gap. So, and I'm not ready to say that was necessarily related to the ACT versus no ACT in there. But definitely a large driver of that difference in annual utilization trend. All right, so we move on to knee arthroscopy. You can see it's basically, we had a convergence actually in the 11-12 plan year. So we did see a continued drop from the 9-10 all the way to the 11-12 plan year. So both during the year of implementation and after. And since then, the OEB plan has generally been a little bit above, and the book of business a little bit lower. We did see a little bit of spreading of that gap with the 18-19 plan year. And knee replacements, kind of a similar story in there, where for the 18-19 plan year, we did see a significant drop in the OEB utilization, down from 3.2 per thousand all the way down to just about 2.5, and we saw a much more modest reduction in the book of business. So that brought those much closer together, and really has resulted in a shift from last time, where last time we had seen the OEB utilization higher on the long term than the book of business. That has reversed itself with the addition of the latest plan year. But again, not. We can see that 1 year can make a pretty significant difference in how these are evaluated. All right, so if we look at shoulder arthroscopy, similar type of story as we just saw, very favorable for the OEB plan year. I will just remind everyone, this is all pre-COVID, so sometimes when we look at these really big drops, we think, oh, that's COVID, let's not worry about that. But this is just to the end of the 18-19 plan year. So all pre-COVID. Sleep studies. We actually saw a little bit of an increase in the OEB and a decrease in the OEB and an increase in book of business there. So long-term having, maybe a little bit of an impact. We see almost a 2% spread for that one. And then spine surgery, we see a reduction in both the OEB and book of business on the long term, with a little larger reduction on the book of business, but generally you can see they're very, very close. Sometimes the numbers will tell us one thing, but visually we can see that, yeah, there's some ups and some downs, but they're pretty close. They're tracking very close to one another. That was on the, the spine surgery injections. And this is a case where we sort of have the opposite of what we saw earlier, where we saw a pretty big drop for spine surgery in the MOTA book of business and a little bit of an increase in the OEB experience. So that resulted in while still a reduction, a larger reduction for the book of business over the long term versus the OEB plan. Endoscopies rolling along pretty similar, slightly better utilization trend for the MOTA book of business. But again, as we can kind of see, some years were a little bit higher, some years right on, and some years a little bit lower. In general, long-term, very similar trending impacts. Any questions on those details before we dive in sort of to the PM data?
I know we've seen these graphs before, but if I were just looking at, the dates from, if I cut out 10, 11, and I start with 11, 12, and I'm looking at those, I see a correlation, but I'm still concerned I don't necessarily see a causation or an impact by the ACT on that. So it's not really a question, it's just my uninformed observation.
Yeah, I think it gets back to sort of what does it look like from an eyeball perspective and what does it look like from a math perspective. I have the advantage of having this really large detailed spreadsheet that I looked at things 18 different ways and did weighted by this and weighted by that. And I looked at it this way and that way. And every way I looked at it, in general, it looked like when I looked at everything across all of the utilization categories, which is hard to do because utilizations are not created equal, right? An MRI, service is much different than a spine surgery service. But when you take all those factors into consideration, it was about 0.1 to 0.2% difference, with the advantage being to the OEB plan. And when I sort of take that numerical magnitude, and I think that's a pretty small magnitude over the 11-12 plan year through the 18-19 plan year, it's probably within what we would just call a normal statistical variation. So I think what I'm in a very long way, what I'm saying is that I think I agree that, both from an eyeball and a numerical standpoint, I'm not sure there's a lot of support for incremental change. I think what we can say is that there was some initial impact and we haven't really seen that impact go away yet. So we haven't seen a big drop followed by a bigger increase for the OEB plan. Does that help answer your question, or?
Yes, thanks.
Okay. I can send you my spreadsheet too. All right. So
I would still be uninformed with it, so that's fine.
It's got a lot of colors in it, though. So when we looked at the PM, so everything we were just looking at was sort of just our utilization, how the use of the services were going, and I think that was, from an ACT perspective, that was the goal of the ACT, was to get people thinking about how they're using services, not necessarily how much each of those services cost, and how that cost was changing on a yearly basis. But we did go through and look at it. And, interestingly, when we looked at all of these services together, because it's much easier to look on a PM basis and establish, the OEB experience versus book of business experience, we did see a very distinct 1% per year difference between the OEB plan and the book of business plan, where OEB, over the course of those last 7 or so years, from the 11-12 plan year through the 18-19 plan year, the OEB plan did perform on a PM basis 1% better per year, which is really great. Just thinking at a high level, if I have my total cost coming in about 1% lower, and I think that my utilization was maybe 0.1, 0.2% lower, that really tells me, at a very high level that it feels like unit cost, or cost per service difference is driving a lot of that PMPM change. So I would say between 8 and 0.9% of that. So 80 to 90% of that favorability, I think, is driven by unit cost. And that could be a combination both of aggressive and successful contracting, with facilities and providers. Also important to remember that we do have that reference-based pricing program that Moda discussed earlier in our meeting as well. So both of those things I think could provide some reason for that as well. But regardless, very favorable and great results there. I'm not going to spend a ton of time going through the PMPMs. In general, we can kind of go through and do those same sort of looks and see, from an eyeball perspective, we'll usually see a drop in the between 9, 10 and 10, 11, and then see things bouncing around a little bit. Not a tremendous amount of change from an MRI perspective on there. We did, again, hip replacements was one area that really did seem to be driving a lot of difference. We can see that particularly on a PMPM perspective, the last couple of years have really helped OEB's positioning on that. We've dropped quite a lot, almost 20% in the last 2 years on a PMPM basis. And I think a lot of that, when I went and did my poking around, a fair bit of that was utilization versus the unit cost. Appeared to be that way. So that was a pretty good success story. The arthroscopy, we did have a little bit of a pop-up there. Knee replacements, we had again a very large decline in there. And then shoulder arthroscopies, very large decrease in our PMPMs. I think that was the 18-19 plan year was, more driven, I think, by utilization in there. Sleep studies, not a tremendous amount of difference in there from an eyeball perspective. And then spine surgeries, looking like, very close. Again, OEB from a overall perspective, being a little bit under from a magnitude perspective, and even a little bit better from the injections from a trend perspective. And then the spine surgeries actually having kind of the opposite results, where you see the surgery cost itself, the OEB plan typically above the book of business, and a little bit higher trend as well. We have a little bit of data for endoscopies, a little bit higher trend for the OEB plan than book of business, but not too far off. Any other comments on the PMPMs costs before we move on to the copays? All right.
I'm good.
Okay. So, I think this answered a little bit of this addresses a little bit of the copay question that was brought up. And I think in particular, hey, how much magnitude, are we seeing from this, these copay savings? And we can see that in that first year where we had a lot of people hitting those and running into those copays, we had almost 3.4 million of copays in there. That number has steadily dropped, even though we did add a few procedures during the subsequent few years, to the point where we're down at about 1.3, 1.4 million for the 18-19 plan year. So, really very stable, more stable copay levels since the 2016-17 plan year in there. And that represents approximately 0.2% of our medical costs. Questions on that? All right, so kind of looking at it on a by procedure basis gives some interesting perspective on what's driving that drop. We saw, no surprise, we saw those very high, highly utilized procedures, our advanced imaging having very high copay levels, and subsequently dropping off a lot, which is, it's great to see. We saw some very steep curves. We also saw some of that in the spine injections, a few other services in there, and then we had a few of the flat ones in there that really didn't have a tremendous amount of movement or impact in there, quite a few of those services. Any questions on the copays?
Yeah, Brad, just clarification for me. When it says copays, that means the ACT copays, or is it broader than that?
I believe that was, that's a good question. I'm guessing it's going to be the total cost share associated with that procedure is what I'm going to guess. So that's a good clarification. Let me jot that down and we can shoot that back out to you.
What's the total?
Pardon?
If we add all these together, what is the total?
That would be right back up here at the 1.354 million. For the latest plan year.
Oh, okay, that's the page before. I'm looking.
Yeah, so each of this is really just a breakout by procedure, and you could go calculate them up, and in theory, they would all total to these numbers by year.
Thank you.
Mm-hmm. Right. So, kind of key observations. Again, we did see some sustained cost decrease. It looks like not too much of that is related to utilization. There is a potential that if we, remove these programs, we may see a pop-up of services. That's a little bit subjective. It's not something that I've seen in my career with things like pharmacies. When you take your formulary restrictions away, people don't just rush out and to get all these services. That said, we have been in the innovation work group reviewing expert medical opinion centers of excellence. These various concepts, we think they would integrate well with the ACT program. So we do recommend continuing with the ACT program, particularly if we have not been hearing a lot of noise or issues with it, for the current year until we, kind of finalize these centers of excellence and expert medical opinion programs and kind of see how best to coordinate all of these different program features.
Thank you, Brad.
Mm-hmm.
Any additional questions from the SEOW members?
I probably have more of I have a comment, not a question. So
okay.
Even if you assume that the ACT actually impacts utilization, I think we need to look at the equity implications of that and the ability to afford. It'd be good to know, and I know we probably don't have the data, but it appears to me that the ones that are least likely to decide against those procedures based on the ACT are the ones that are least likely to be able to afford it, which would include a significant portion of people of color as well. So.
The impact of cost of care is, that's the lever that's being pulled, and in a society where there's significant inequality when it comes to income, I think you're right on, Robert. I don't know how to answer that's a huge issue overall, and I'm not sure what the forum should be around which we address that. Jeff, do you have an idea?
I'm afraid my brain is racing on to other things.
Okay, fine. Well, we will. I'll raise the issue at the SEOW report, and we'll then think about where the conversation that, or the comment that Robert just made, where it is best addressed, because it's real, and yet, you know, it's things have to be affordable. So it's this it's a catch-22 in many a way.
Absolutely.
Okay. Any other questions? We're about 2 minutes before our scheduled closure time.
I want to say this is a great report, Willis Towers Watson. Good job.
Yeah, agreed.
Oh, thank
Again,
you.
we have high quality consultants at every turn. Okay, so I am going to close the November SEOW meeting, and we re-adjourn at the full board in half an hour.
We do.
Okay.
Thank you.
Bye-bye. Thank you all.